Very specific, very boring image.
Hmm.
It's the little white pill your dad takes. It's the cholesterol pill. It's almost become this background noise in modern medicine. You know, you go to the doctor, the numbers on the lab sheet are a little high, you get a script, you go home, end of story.
That is the surface level narrative,
Yeah.
certainly. It's viewed as the WD-40 of cardiology.
Yeah, just a standard maintenance measure.
But if you actually peel back the layers of the pharmacology, and that is exactly what we're going to do today, the story of statins is not boring at all. It is actually a story about a radical transformation in how we understand, human biology.
I was reading through the molecular biology refresher you sent over. Thank you for that, by the way. It's been a minute since I thought about the endoplasmic reticulum, and I had this realization. This isn't just about lowering a number on a lab test to make an insurance company happy.
Not at all. Not even close.
It's about manipulating cellular machinery. It's about hijacking a survival mechanism deeply embedded inside the liver to save our hearts. And then there's this whole other layer about the 2025 guidelines, these new risk calculators, and the psychology of side effects.
It is a massive landscape. We're essentially talking about the evolution of cardiovascular management from a brute force approach, just hammering down a number, to a precision molecular hack.
A molecular hack. I love that phrasing.
And what's fascinating is that while we've been using these drugs for decades, our understanding of how to use them, and frankly, who needs them, has completely shifted in just the last year or two.
Okay, so for everyone listening, here is our roadmap for this deep dive. We are going to start small, literally microscopic. We need to understand what is happening inside the cell when you swallow that pill. We're going to talk about the mevalonate pathway.
The engine room of cholesterol production.
Right. Then we're going to look at what the researchers call the hidden menu of benefits. The stuff statins do that has absolutely nothing to do with cholesterol. They call this pleiotropy, which is a fantastic Scrabble word if you can find a place to play it.
It really is.
Mm-hmm.
And it explains why statins seem to work even when cholesterol isn't the main problem.
Then we're going to fast forward to right now, the landscape of 2025. We're going to look at how doctors are changing the way they predict heart attacks, moving from the old pooled cohort equations
The PCs.
to this new system called PREVENT.
A huge shift in the standard of care. It's changing how we define risk.
And finally, we have to talk about the elephant in the room, muscle pain. Is it real? Is it in our heads? And how do we tell the difference? We've got a scoring system called the SAM-SCI score that we really need to unpack.
It is a vital tool for anyone taking these drugs, or even just thinking about them.
So we have a lot to cover. Let's jump right in with the premise. When we talk about statins, we are technically talking about HMG-CoA reductase inhibitors.
That is the chemical name, yes.
Which sounds terrifyingly technical, but let's unpack the mechanism. Where does the action happen? When I swallow that pill, where does it go?
It heads to the liver. The liver is the command center for all of metabolism. Specifically, it enters the hepatocytes, the liver cells.
Okay.
And if you want to get really specific, we should, the action takes place inside a cellular structure called the endoplasmic reticulum.
The ER. I remember diagrams of that from high school biology. It looks like a maze of folded sheets.
Exactly. It's the manufacturing plant of the cell. Now imagine a factory line inside that ER. The goal of this factory line is to build cholesterol. And we have to pause here and clarify something because cholesterol gets such a bad rap.
Right. It's not a poison.
No, it's a building block. Your body makes its own cholesterol because it needs it.
What for?
You need it to build cell membranes so your cells don't just fall apart. You need it to make bile acids to digest your food. You need it to synthesize hormones like testosterone, estrogen, cortisol, the important stuff. If you had zero cholesterol, you wouldn't be alive.
So the liver has this assembly line just running 24/7 to keep the supply up.
Correct. But the process of making cholesterol is a long chain of chemical reactions. It's a multi-step synthesis. And like any assembly line, there is a bottleneck.
Okay.
A specific step that controls the speed of the whole operation. That step is catalyzed by an enzyme called HMG-CoA reductase, or HMG-CR for short.
So HMG-CR is the foreman of the cholesterol factory.
Think of it more like the gatekeeper. It catalyzes the conversion of a molecule called HMG-CoA into another one called mevalonate. This step is what we call the rate-limiting step.
The point of no return.
Exactly. If this step happens, the cholesterol gets made down the line. So you block this step, the whole production line shuts down.
Okay, so enter the statin. How does the drug actually stop this enzyme? Does it just smash it? Does it blow up a factory?
It's much more elegant than that. It's really a case of mistaken identity. It's chemical espionage.
Ooh, I like that.
If you look at the molecular structure of a statin, specifically the pharmacophore, which is the active part of the drug molecule, it looks remarkably similar to the natural HMG-CoA molecule.
So it's a disguise. It's wearing a fake mustache and glasses.
Precisely. The enzyme, HMG-CoA reductase, has a binding, like a lock, if you will. It's waiting for the HMG-CoA key to come along so it can do its job.
Right.
But the statin molecule swoops in first. Because it looks so much like the key, it fits into the lock with very high affinity.
Competitive inhibition.
That's the term. It sits in the active site and just stays there. It occupies the space. It physically blocks the real HMG-CoA from getting in. The enzyme is occupied, but it's not making mevalonate. It's jammed.
So the factory line grinds to a halt. The liver cell stops making its own cholesterol.
Correct. And this is where it gets really interesting. This is the part that I think most people don't realize at all. The lowering of cholesterol in your blood doesn't happen just because the factory stopped. That's only half the story. If the factory just stopped, you'd stop adding new cholesterol, sure, but you wouldn't necessarily clear what's already circulating in your arteries.
Right. Okay, so where does the cleaning come from?
It comes from the cellular panic.
The cellular panic. That sounds dramatic.
It is dramatic. From the cell's perspective, it's a crisis. When you block that enzyme, the level of cholesterol inside the liver cell drops precipitously. The cell senses this. It has sensors that realize, wait a minute, I'm starving. I don't have enough sterols to maintain my membranes.
It thinks it's dying.
It thinks it is in a resource crisis, absolutely. This triggers an intracellular signaling cascade. There are these proteins called SREBPs that stands for sterol regulatory element binding proteins.
Okay, SREBPs.
Normally, they are tied up, they're inactive, anchored to the endoplasmic reticulum. They are essentially in storage, waiting.
Waiting for what?
Waiting for a signal. When cholesterol levels drop, the cell releases protease. Think of them as molecular scissors that come in and cleave these SREBP proteins.
They cut them loose.
They cut them loose. These newly cleaved proteins then travel, they translocate right into the nucleus of the cell.
The command center.
Right into the command center. And there they bind to specific DNA sequences called sterol response elements, or SREs.
So they are basically running to the captain of the ship and screaming, "We are out of supplies. We need more cholesterol immediately."
That is a perfect analogy. And the nucleus response, it turns on a whole host of specific genes to solve the shortage. And the most important gene it turns on is the gene for the LDL receptor, or LDLR.
The LDL receptor.
Think of the LDL receptor as a mouth, or a vacuum hose on the surface of the cell. The liver cell realizes it can't make cholesterol effectively because of the statin, so it decides to eat cholesterol from the bloodstream instead.
It's going scavenging.
It starts building thousands and thousands of these LDL receptors and putting them all over its outer membrane.
This is the aha moment for me. The drug doesn't just stop production, it forces the liver to suck cholesterol out of the blood to save itself.
That is the primary mechanism of LDL lowering. The liver upregulates these receptors. They reach out into the blood. They grab passing LDL and VLDL particles, which contain a protein called apolipoprotein B100, and they pull them inside via endocytosis.
They just swallow them whole.
And destroy them in lysosomes. They're just gone from the circulation.
So the statin is essentially tricking the liver into cleaning the blood.
That is a perfect way to put it. It creates an artificial famine inside the liver, so the liver goes on a feeding frenzy, eating up the LDL from your circulation.
That is incredibly cool. It's biology judo. You're using the body's own survival instinct against the disease itself.
It is. But that's just the cholesterol story. Remember we talked about the roadmap?
Right, the pleiotropic effects, the stuff that isn't about cholesterol.
Exactly. This is where we move beyond just the numbers on a lab report. Because when you block HMG-CoA reductase, you aren't just stopping cholesterol. You are blocking the whole mevalonate pathway.
Okay.
And that pathway creates other crucial things besides cholesterol.
Intermediate steps in the factory line.
Yes. We call them isoprenoids. Specifically, there are two key molecules called farnesyl pyrophosphate, or FPP, and geranyl pyrophosphate, or GGPP.
Those are fun to say. Geranyl?
Try saying that 5 times fast. But these isoprenoids are critically important. They're used for something called protein prenylation.
Okay, let's unpack that. Prenylation. What is it?
Imagine you have a small protein inside the cell. Let's call it a messenger. For this messenger to do its job, to stick to the cell membrane and send signals, it needs a little sticky tag attached to it. That sticky tag is an isoprenoid, like FPP or GGPP.
So prenylation is the process of attaching the sticky tag, like putting a stamp on a letter so it gets delivered.
Exactly. Or putting a handle on a suitcase so you can carry it where it needs to go. Without that tag, the protein just floats around uselessly in the cytoplasm. It can't anchor itself to the membrane.
But what kind of proteins need these tags?
Some very important ones. Small GTP-binding proteins like Rho, Ras, and ROC.
Rho, Ras, and RAC. They sound like a trio of cartoon villains.
In the context of heart disease, they kind of are. These proteins control things like inflammation, cell shape, oxidative stress, and smooth muscle contraction in your blood vessels.
So if I take a statin, I'm blocking the production of the raw materials for these sticky tags, the isoprenoids,
Yes.
which means these proteins, Rho, Ras, and Rus, can't get their tags, they can't stick to the membrane, they can't do their job.
And in this case, stopping them from doing their job is actually a very good thing for the heart and blood vessels.
How so? What's the benefit?
Well, take Rho, for example. When Rho is active in your blood vessel walls, it promotes the contraction of the vessel and triggers inflammatory pathways. It makes the vessels stiff. By blocking the isoprenoid tag, we inhibit Rho. The result, the enzyme Rho-associated protein kinase gets downregulated. This leads to increased nitric oxide bioavailability.
Nitric oxide, that's the vasodilator, right? It makes blood vessels relax.
Correct. It improves endothelial function. It makes your arteries more flexible, more pliable, better at regulating blood flow. It prevents them from being stiff and reactive.
So even if your cholesterol didn't drop a single point, the statin is still making your blood vessels healthier just through this mechanism.
That is the whole theory of pleiotropi, and it goes even further. Inhibiting these proteins also reduces oxidative stress and attenuates systemic inflammatory responses. It also helps stabilize the plaque that's already on your artery walls.
Stabilizing the plaque, that means preventing it from rupturing, which is what causes the heart attack.
Exactly. A heart attack usually happens when a soft, inflamed plaque bursts and forms a clot. If the statin can make that plaque harder, more calcified, and less inflamed, it's much less likely to pop. That prevents the event.
This explains so much. It explains why statins seem to work for so many different people, even those without crazy high cholesterol.
And we have fantastic evidence for this. The Jupiter trial.
Ah, yes, the Jupiter trial. This was a big one in the research stack, a game changer.
Huge. This trial completely challenged the dogma of the time. It looked at people who did not have high cholesterol. Their LDL was low, less than 130 milli-GDL. By the standards of the day, they were fine.
They were apparently healthy.
Right, they would have been treated. But they had high inflammation. Their high-sensitivity C-reactive protein, or hsCRP, was elevated above 2.0 milli-GL.
So normal cholesterol, but their bodies were inflamed. What did they do?
They gave them rosuvastatin, 20 milligrams, a potent statin, and the results were so dramatic they had to stop the trial early.
That's always a distinct marker in research when the ethics board steps in.
In this case, it was a very good sign for the drug. There was a 44% reduction in the primary endpoint, heart attacks, strokes, cardiovascular death. A 44% reduction in people who started with normal cholesterol.
That is massive.
It is, and it really cemented the idea that statins are not just lipid-lowering drugs. They are vascular protective drugs that work on inflammation and endothelial health, too.
It really challenges the whole cholesterol is the only thing that matters mindset.
It does. It tells us that inflammation is a key driver of risk, and treating it via this pleiotropic pathway we just discussed saves lives.
Okay, so we've covered the biology, we know how it works, but as we know, not all statins are created equal. I was looking at this chart in the notes, type I versus type 2, hydrophilic versus lipophilic. It's like a personality test for drugs.
It sort of is, and understanding this diversity is absolutely key to clinical management, especially when dealing with side effects. Not every statin fits every patient.
Let's start with the type. Type I versus type 2. What's the difference?
This is mostly historical, but it's interesting. Type I are the fungal derivatives, lovastatin, pravastatin, simvastatin. They are structurally similar to the very first discovery, mevastatin, which was isolated from a fungus.
So they're natural, organic, artisanal statins.
You could say that.
Yeah.
Nature invented the molecule to fight off microbial competition. Then you have the type 2 atorvastatin, rosuvastatin, pitavastatin. These are fully synthetic. They were designed in a lab to be more potent and usually have longer half-lives.
But the bigger distinction for the patient seems to be the hydrophobicity spectrum, whether the drug loves fat or loves water.
This is crucial for side effects. Absolutely crucial. We have lipophilic statins, fat-loving. These are atorvastatin, simvastatin, lovastatin.
Okay.
Because cell membranes are made of fat, of lipids, these drugs can diffuse passively right through the membrane.
They can walk through walls.
Essentially, yes.
Yeah.
They can enter the liver cells very easily, which is good. That's what we want. But they can also enter other cells easily, like muscle cells.
Ah, and that's where the trouble can start.
Potentially.
Yeah.
If the drug gets into the muscle tissue in high concentrations, it can interfere with muscle metabolism, which can lead to toxicity or pain. Now, compare that to the hydrophilic statins water-loving, rosuvastatin and pravastatin.
They can't walk through walls.
No, they sort of bounce off the lipid membrane. To get into the liver, they need a special ticket. They rely on active transport proteins on the cell surface, specifically one called OATP1B1.
OATP1B1.
Catchy. It's a transporter that literally grabs the drug and pulls it into the liver. Because this transporter is mostly found on liver cells, hydrophilic statins are what we call hepatoselective.
Liver selective.
Right. They concentrate in the liver and are much less likely to passively drift into your biceps or your quads.
So in theory, if I'm a patient and I'm worried about muscle pain, I might want to start with a water-loving statin like rosuvastatin.
That is often the clinical strategy, yes. Switch from a lipophilic to a hydrophilic one. Although we should note that at very high doses, even the selective ones can spill over. But mechanistically, yes, that is the advantage.
Now, what about grapefruit juice? I feel like everyone's grandma knows you can't drink grapefruit juice with statins. Is that an urban legend or is that real?
No, it is hard biochemistry. It comes down to metabolism. Yeah. Specifically, the cytochrome P450 system in your liver and gut. There's a specific enzyme called CYP3A4.
CYP3A4, that's the workhorse enzyme, right? It chews up a ton of drugs.
It is. It metabolizes about 50% of all drugs, including atorvastatin, simvastatin, and lovastatin. It resides in the intestinal wall and the liver.
Okay, so how does grapefruit fit in?
Grapefruit juice contains these compounds called furanocoumarins. These compounds irreversibly inhibit CYP3A4 in the gut wall.
So if I drink the juice, I'm knocking out the enzyme that breaks down the drug.
Exactly. So the drug levels in your blood can spike. You might be taking a 20-milligram pill, but your body absorbs it as if you took 80 milligrams or even more. That drastically increases the risk of toxicity, especially muscle issues.
But not all statins use this pathway.
No, and that's key. Rosuvastatin and pitavastatin are different. Rosuvastatin is catabolized very little, and what is mostly by a different enzyme, CYP2C9. Pitavastatin also uses CYP2C9, so grapefruit juice isn't really an issue for them.
Good to know. If you love grapefruit, ask for rosuvastatin.
Or just lay off the grapefruit while you're on the other ones. That's probably safer.
Fair point. Now let's talk about power. Efficacy. We hear about high-intensity statins. What does that actually mean? Is it just a higher dose?
It's defined by the result. A high-intensity regimen is one that, on average, lowers your LDL-C by 50% or more.
50% reduction. That's the benchmark.
That's the benchmark for high intensity, right? And to get there, you really need the big guns. That's atorvastatin, 40 to 80 milligrams, or rosuvastatin, 20 to 40 milligrams. Those are the only two that consistently qualify as high intensity.
What about moderate intensity?
That's a 30% to 49% reduction. That could be lower doses of atorvastatin or rosuvastatin, or standard doses of simvastatin, pravastatin, and the others.
And here is where it gets really interesting to me, and I think counterintuitive. The rule of 6.
Yes, the rule of 6. This is a vital concept for understanding why we don't just keep doubling the dose forever and ever.
Explain it to us.
Okay, let's say you are on 10 milligrams of atorvastatin, and your doctor doubles your dose to 20 milligrams. You might expect your cholesterol drop to double as well.
Logical assumption. Twice the drug, twice the effect. Makes sense.
But biology isn't linear. It follows a logarithmic curve. Doubling the statin dose typically only yields an additional 6% reduction in LDL-C.
Only 6%, that's it.
Just 6%. You get the vast majority of the benefit from the initial starting dose. That first 10 milligrams does most of the heavy lifting. After that, you are fighting a battle of diminishing returns.
So going from 10 milligram to 20 milligram gives you about 6% more. Going from 20 milligram to 40 milligram gives you another 6% on top of that.
Exactly. And going from 40 milligrams to the maximum of 80 milligrams, you guessed it, another 6%.
So you're exponentially increasing the amount of drug in the body, which could potentially increase side effects, but you're only inching down the cholesterol number.
Which is precisely why, if someone is really far from their goal, just doubling the statin might not be the best strategy. You might need to add a different type of drug, like ezetimibe, which works on absorption in the gut, not production in the liver. It's a different mechanism.
That makes a ton of sense. It explains why we see combination therapy so often now.
It does. But we should highlight the Stellar trial here. With head-to-head comparison, it showed that rosuvastatin is, pound for pound, the most potent. Rosuvastatin 40 milligram achieved about a 60% reduction in LDL. It outperformed the equivalent top doses of everything else.
So it's the heavyweight champion of the class.
In terms of pure LDL lowering, yes, it is.
Okay, let's pivot. We've covered the drug itself in detail. Now let's cover the guidelines. Because 2025 has brought some pretty significant changes.
Very significant changes. The landscape of risk prediction has fundamentally shifted.
For the last decade or so, doctors use the PCE, the pooled cohort equations.
Right. If you went to the doctor in, say, 2018, they plugged your numbers into the PCE calculator. Age, race, smoking status, blood pressure, cholesterol. It would spit out a percentage, your 10-year risk of having a heart attack or stroke.
But there were problems with the PCE, weren't there?
There were several. It was based on older data sets, some of which went back to the 1990s or even earlier. And populations have changed. Diets have changed. Treatments have changed. The PCE was often criticized for overestimating risk in modern diverse populations.
So it was telling people they were high risk when they really weren't, potentially.
In some cases, yes. And it wasn't very diverse. It didn't account for a lot of modern variables that we now know are really important.
Enter the prevent equations.
The predicting risk of cardiovascular disease events. This is the new standard as of the 2024-2025 guidelines from the American Heart Association.
What's different? What does it add?
First, the scope is broader. The old calculator only looked at ASCVD, atherosclerotic cardiovascular disease. That's basically heart attacks and strokes. Prevent looks at total CVD.
What does total CVD add to the equation?
Heart failure.
Ah, that's a big one.
It's a massive one. Heart failure is a huge and growing epidemic. Prevent incorporates the risk of developing heart failure into your overall score. It also brings in kidney health, your eGFR, and your metabolic health status.
So it's a much more holistic look at the body's systems.
Much more. It uses variables the old one didn't. Obviously, it still uses age, cholesterol, blood pressure, smoking, diabetes. But it also includes things like the urine albumin to creatinine ratio, the UACR.
A measure of kidney leakage.
Yes. And it allows for optional personalization with things like your HbA1c. And this is fascinating. The social deprivation index, or SDI.
Wait, social deprivation index, it asks about your socioeconomic status?
It acknowledges that social determinants of health, where you live, your access to resources, your daily stress levels, are major drivers of cardiovascular risk. That is a huge step forward in recognizing the reality of medicine. It's not just biology, it's your environment.
That is fascinating. So what's the bottom line? Does Prevent give higher or lower risk scores than the old PCE calculator?
Generally, lower.
Lower. That seems counterintuitive if we're adding a whole new disease like heart failure.
It does, but it's because it is better calibrated to the modern population. As a whole, we smoke less, we treat blood pressure more aggressively than we did in 1990. So the absolute risk estimates tend to come out lower than the old, often inflated PCE numbers.
Does that worry people? If the score is lower, does that mean fewer people will qualify for statins?
That is the big controversy right now. Some experts are worried we might undertreat people who would have qualified under the old, more aggressive thresholds. But the counterpoint is that Prevent is simply more accurate. And it actually identifies risk in people who aren't currently on treatment more effectively, especially by using those renal and metabolic markers.
So who gets a statin in 2025? What are the new rules of the road?
There are still some groups where you don't even need a calculator.
The automatic qualifiers.
Exactly. If your LDL is 190 or higher, that's severe hypercholesterolemia. You go straight to a high-intensity statin. Do not pass there. Do not collect $200.
Clear enough. That pretty much suggests a genetic issue at that level.
Right. And if you have diabetes and are between age 40 and 75, moderate intensity statin is the default recommendation.
Because diabetes itself is such a strong risk equivalent.
Precisely. For everyone else, what we call primary prevention, age 40 to 75, we look at the risk score. If you are high risk, which is now defined as a 10% or greater 10-year risk, you initiate a moderate intensity statin. If you are low risk, less than 5%, then generally no statin is needed.
And what about the messy middle?
The intermediate risk group, 7.5% up to less than 10%. That's where the art of medicine really comes in. It's not an automatic prescription. That's where we look for risk enhancers.
The tiebreakers.
Exactly. Things like a strong family history of premature heart disease, chronic kidney disease, chronic inflammatory conditions like lupus, rheumatoid arthritis, HIV.
Because as we said, inflammation drives risk.
Correct. And we also look at biomarkers that aren't in the main calculator. Persistently elevated HSCRP or a high lipoprotein, which is a genetic risk factor. If you have these enhancers, it tips the scale in the discussion towards starting the drug.
It sounds much more personalized than the old check-the-box method.
It is precision prevention. We are moving away from treating the average patient and trying to treat the specific patient who is sitting in front of us.
Okay, so let's say the patient fits the criteria. They get the prescription, they take the pill, and then their legs start hurting.
Statin-associated muscle symptoms. SAMAS.
This is the #1 reason people stop taking them, right?
Yeah.
It has to be.
It is a significant contributor to non-adherence, a huge one. And it's a very tricky topic because there is this massive discrepancy in the data.
What kind of discrepancy?
If you look at the randomized controlled trials, the gold standard double-blinded studies, the rate of muscle symptoms is very low. We're talking 1% to 5%.
Yeah.
And often it's the same rate in the placebo group.
Wait, people taking the sugar pill got muscle pain at the same rate?
Yes. But if you look at real-world observational studies, the rate is much, much higher. Anywhere from 5% to as high as 30% of patients report muscle pain.
Why the gap? That's a huge difference. Why is the real world so much worse than the pristine world of the clinical trials?
The nocebo effect.
Placebo's evil twin.
Precisely. Placebo is when you expect a benefit, so you feel better. Nocebo is when you expect a harm, so you feel worse. You've read the pamphlet, you've seen the commercial, you're waiting for the pain to start.
Is there actual proof this is happening with statins?
There was a fascinating study mentioned in our source material, the Samson trial. They had patients in 2 phases. In the blinded phase, patients didn't know if they were taking a statin or a placebo pill that looked identical.
Okay.
In that phase, muscle complaints were very low. Then they switched to an open-label phase where the patients knew they were taking a statin. The reporting of muscle pain skyrocketed. It was significantly, dramatically more pain reported when they knew they were taking the drug.
That is wild. It really shows the power of the mind. But, and I have to play devil's advocate here, if a patient is in pain, they're in pain. We can't just tell them it's all in your head.
Absolutely not. The pain is real to the patient, the suffering is real, but the cause might not be their pharmacological action of the drug. It might be the anticipation. Or it might be that they're older, they exercised too hard that day, or they have underlying arthritis.
So how does the doctor figure it out? How do you distinguish true SAMs from I slept funny or nocebo?
This is where we use the SAM-CI, the Statin-Associated Muscle Symptom Clinical Index.
It's a scorecard.
It is. It's a validated tool that assigns points to the characteristics of the symptoms to determine the probability that the statin is the true culprit.
Let's run through it. What gets you points on this scorecard?
Okay, first, location and pattern. If the pain is symmetric, meaning it's on both sides of the body, and it's in the hip flexors, thighs, or upper proximal muscles, that gets high points, 2 or 3 points. If it's asymmetric, like just your left knee, or it's nonspecific and all over, that gets low points, 1 point.
Okay, so both of my thighs are aching is classic statin pain. My right shoulder hurts is probably not.
Correct. Next is timing. If the symptoms start within 4 weeks of starting the pill, that's suspicious, 3 points. If it starts between 4 and 12 weeks, 2 points. If it starts after 12 weeks, it's less likely to be the drug, only 1 point.
So immediate onset is a big red flag.
Yes. Then we have D-challenge. This is crucial. You stop the drug. If the pain goes away in less than 2 weeks, 2 points. If it takes longer than 4 weeks or doesn't go away at all, 0 points.
And the final test, the ultimate proof.
Re-challenge. You restart the same drug at the same dose. If the same symptoms come back within 4 weeks, 3 points.
That's the smoking gun.
It absolutely is. Then you add up the points. If your total score is 9 to 11, it's probable SAMs. If you score between 7 and 8, it's possible. And if you score from 2 to 6, it's unlikely that the statin is the cause.
I love that. It takes the emotion and the guesswork out of it. It's data-driven.
It helps the clinician and the patient look at the situation objectively. Because the last thing we want to do is stop a life-saving drug for a knee ache that was actually caused by gardening.
But let's talk about the really scary stuff for a second. Rhabdomyolysis.
The nightmare scenario. The thing everyone fears.
How common is it, really?
It is extremely rare. We define myopathy as muscle symptoms plus a CK level, that's creatine kinase, a muscle breakdown marker, greater than 10 times the upper limit of normal. That happens in about 1 in 10,000 patients per year.
1 in 10,000, so very, very low odds.
But rhabdomyolysis is even rarer than that. That's a CK greater than 40 times normal, plus evidence of organ damage like renal failure. It's a true medical emergency, but it is a very, very remote risk for the average person.
What about the risk of diabetes? I've heard that statins can raise your blood sugar.
That is true. There is a small but statistically significant increase in the risk of developing new-onset type 2 diabetes. This is seen especially in people who are already at high risk, people who are pre-diabetic or have metabolic syndrome.
So does that mean those people should avoid statins.
No.
Yeah.
The consensus from all the major societies is overwhelming. The cardiovascular benefit preventing a heart attack or a stroke far outweighs the risk of a slight increase in blood sugar. It's a trade-off, but it's a very favorable one.
Okay, so we have a patient who scores high on the SAM-CI.
Okay.
They have true intolerance. They can't take atorvastatin 40 milligram. What do? Do we just give up?
Never. We never give up.
Yeah.
We manage it. We have a stepwise approach.
No, step one?
De-challenge, stop everything for 2 to 4 weeks, let it wash out of the system, confirm the pain actually goes away.
Step two?
Switch characteristics. If they were on a lipophilic statin like simvastatin, we switch to a hydrophilic one like rosuvastatin or pravastatin. As we discussed, those tend to stay in the liver and spare the muscle.
Step three.
This is my favorite trick in the book, intermittent dosing.
The weekend warrior statin.
Exactly. Because rosuvastatin and atorvastatin have very long half-lives, you don't actually need to take them every single day to get a significant benefit. You could prescribe rosuvastatin 5 or 10 milligrams just twice a week or 3 times a week.
And that works. You can get a meaningful cholesterol reduction from that.
It works surprisingly well. It can lower LDL by 20–30% or more, but it gives the muscles a break in between doses. Many patients who are deemed intolerant can tolerate this perfectly.
And if even that fails, what's step four?
Then we go to combination therapy with non-statins. The first and easiest step is to add ezetimibe.
Ezetimibe.
It blocks cholesterol absorption in the gut. The IMPROVE-AT trial proved that lower is better for LDL regardless of how you get there. Adding ezetimibe to a statin reduced cardiovascular events significantly.
So you could use a tiny, well-tolerated dose of a statin, maybe intermittently, plus ezetimibe, and get a really big effect.
Exactly. Or, if that's not enough, we move to the new stuff, PCSK9 inhibitors, or the newer oral agent, bempedoic acid.
Tell me about bempedoic acid. That's a new player on the block, right?
It is, and it's fascinating because it works on the same cholesterol synthesis pathway as statins, but it hits a different enzyme. It inhibits ATP citrate lyase, which is a step upstream of HMG-CoA reductase.
So why is that better for muscles?
Because it is a pro-drug. It's completely inactive when you swallow it. It only gets activated by an enzyme that exists exclusively in the liver. Skeletal muscle does not have that activating enzyme.
So it's literally impossible for it to work in the muscle?
Theoretically, yes.
Mm-hmm.
It's designed to completely avoid muscle toxicity because it's not active there. It is a liver-specific weapon.
That is some incredibly smart drug design.
It is. And then there is inclisiran, the siRNA therapy.
Small interfering RNA, the gene silencing stuff.
Right. It's an injection you get just twice a year. It silences the gene that produces the PCSK9 protein. It's almost like a vaccine for cholesterol, at least in terms of the schedule.
The future is getting wild. But before we wrap up, I want to touch on one last debate. Lifestyle versus statins. You hear this all the time. I don't want a pill, doc. I'll just eat better and exercise more.
And let me be absolutely clear. Lifestyle is the bedrock. A heart-healthy diet, regular exercise, weight management, not smoking. Everyone should do it. Full stop.
But is it enough on its own?
The data suggests that for patients who are at intermediate or high risk, it is rarely enough on its own to get them to their goal. An intensive lifestyle intervention reduces cardiovascular risk by about 20%.
20%.
Which is great. That's a huge benefit. But high-intensity statins reduce LDL much more aggressively and have shown larger risk reductions in trials. A Bayesian analysis, a heavy statistical model, estimated that there is an 89.7% probability that statins are more effective than lifestyle alone for event reduction.
So a 90% chance the pill beats the salad.
In terms of acute risk reduction for a high-risk person, yes. But the correct answer is never either. It is always and. Statins are an adjunct to lifestyle, not a replacement for it.
Yeah.
You don't take a statin so you can eat cheeseburgers. You take a statin to amplify the powerful work you're doing with your lifestyle.
That's a really healthy way to frame it. It's a force multiplier. So we've gone from the microscopic mechanism of the HMG-CoA reductase inhibitor to the cellular panic that builds LDL receptors to the pleiotropic magic of isoprenoids through the new prevent equations and down into the nitty-gritty of SAM scores and intermittent dosing.
It has been a journey.
What is the one thing you want the listener to take away from all this, if they remember nothing else?
The legacy effect.
The WS CAP-SINDing.
Yes. The West of Scotland coronary prevention study. It was one of the early landmark trials. They treated men with pravastatin for 5 years. Then the trial ended. Everyone went back to their regular doctors. Some stayed on drugs, some didn't. 20 years later, the researchers went back and looked at the mortality data. The
Damn.
group that had received the statin for those original 5 years still had a 27% lower risk of dying from coronary heart disease.
20 years later.
20 years later, they called it the legacy effect. The decisions you make today, treating the cholesterol, stabilizing the plaque, reducing the inflammation, they echo decades into your future. You are investing in your 2045 self right now.
That gives me goosebumps. It's not just about today's blood test. It's about changing the entire trajectory of your life.
Precisely.
Here's a final thought to chew on then. We talked about prevent and this move toward precision medicine. We talked about genetic risks like LPA. Are we moving toward a world where the average patient doesn't exist anymore, where every prescription is a custom molecular hack tailored to your specific genome and your lifestyle? And deeper than that, if the nocebo effect is powerful enough to conjure real physical pain just from an expectation, how much of medicine is truly molecular and how much is merely mindset?
That is the ultimate question, isn't it? The molecule matters, but the mind matters too.
Thanks for diving deep with us. Go check your lipids.
Stay curious.